Hello, everyone. Rita McGrath here, and I am delighted to be having a second conversation with Anupam Jena, who is this remarkable combination of physician and economist. Publishes the podcast Freakonomics MD, is the author of a terrific book, which came out last year, or just a little over last year, but it's still incredibly relevant. It's out now in paperback, so you've got no excuses not to get it. It's called Random Acts of Medicine, and what the book does is it takes this lens of naturally occurring experiments in the world and looks at how they affect our health. So things like how does removing a toll booth affect the experience of asthma for kids that live around that toll booth? That interesting thing. So welcome. It's such a thrill to have you back again.
Thank you for having me again.
Yeah. So the book came out a little while ago, and I'd love to have you reflect on whether there were any surprises in how it was received or things that have come up since then that you think might be interesting for our listeners to hear about.
I think the reception was good. I mean, I'm biased, obviously, but the book was a lot about the work that my colleagues and I have been doing over the last 10 years or so, stuff that's incredibly fun and interesting. And the concepts aren't very difficult to understand. I think that's what's attractive about the book. And since then, we've been just doing more of the same, sort of trying to find these interesting experiments that are happening in nature that tell us something about how the world works. It's fun work.
Yeah. And some of the stories from the book that stick in my mind are why does cardiac health patient outcomes improve when the cardiologists are all away at a convention? That's really counterintuitive, right?
It is. And I had that idea when I was actually working as a trainee in the hospital during the dates of one of these big meetings when cardiologists were out of town. And it occurred to me that the staffing in the hospital felt a little bit lighter. And so I was curious to see what happened during the dates of those meetings. And what we see is actually that patients surprisingly do better when cardiologists are not in the hospital.
And what did you conclude that was the reason for that?
Well, the other data point I neglected to mention was that rates of stenting, so stenting of the heart vessels, fell by about a third during the dates of those meetings. And so I think the story is something about less invasive or intensive care being performed during those dates. And, the thought experiment is, imagine you have two people. One is a 40-year-old guy who's let's say he's a construction worker. He's got no medical problems and he has a heart attack. If he gets taken to the ED, they show he has a heart attack because he gets an EKG. He goes to a cardiac lab. He gets a stent, gets discharged from the hospital, and lives a long, happy life. So that's one path. The other is a 90-year-old woman who's got a lot of medical problems, but has the exact same chest pain at home one day, goes to the ED, has the exact same EKG, same kind of heart attack, and she also gets a stent. But as a complication of receiving that procedure, she passes away in 2 weeks. Oh. It's not a strange story to imagine, and these are not real stories I'm telling you, but there's certainly things that I think most people in medicine would have experienced one way or the other. But in the second case, you could have anticipated that withholding that level of care, maybe not doing the stent, might have been a better decision in retrospect. It's hard to always know that in advance, but what I think studies like this tell us is that sometimes we do more than we probably should.
I think that's true in medicine. I think it's true in life. In companies, what I see all the time is we're always putting stuff in. And my colleague Bob Sutton makes this point. He says we're always adding. Somebody filed a false expense report. Let's put in a procedure to stop that. And we don't think enough about, well, when is subtraction a better option, or when is not acting a better option? And we're biased that way.
Yeah, I agree.
So you were telling me about some recent research you were doing on taxi drivers and Alzheimer's. I think that would be interesting to hear more about.
Yeah, super interesting. So the backstory is that I think in 2000, so almost 25 years ago now, there was a famous study published about London cabbies.
Oh, yeah, the one about the brain development.
Exactly, yeah. So I'm going to tie it all together for you. Okay. So study published in 2000, which evaluated the brains by MRI scan, so that no one's doing a dissection of the brain or anything crazy like that. But these researchers imaged the brains of London taxi cab drivers. And they did this because these cab drivers had a very special talent. They had to take this test called the knowledge, which required them to know thousands of roads and streets in London, have this memorized before they can officially become a London cabbie. And on top of that, they're using that knowledge on a day-to-day basis, this sort of navigational and spatial memory. And so they knew that that was the case with this type of work. They also knew that the hippocampus is a part of the brain that's involved in navigational and spatial processing. And what they did is they imaged these brains by MRI, and they showed that the hippocampi were enlarged in this enhancing way, suggesting that there was something that was sort of special about these drivers and what they were doing that led to enhancing changes in the brain. So that was a study. Now, fast forward 25 years later, there is new data that's been published by the US, by the federal government, which links all death certificates to the occupation of the person who died. So we have millions of deaths in the US per year linked to the occupation of the person who died. And all we did is we looked at deaths in which Alzheimer's disease was coded on the death certificate as one of the sort of contributing causes of death. And we looked at the occupations of the people who died of Alzheimer's related deaths, or who had Alzheimer's related deaths. And the two occupations with the lowest rates of Alzheimer's related deaths across more than 400 occupations that we looked at were taxi drivers and ambulance drivers.
Huh.
And the reason that's important is because the hippocampus, that same part of the brain that was shown to be larger in these London taxi cab drivers, the hippocampus has also been implicated in Alzheimer's disease. And so our hypothesis was, all right, well, we know that London cabbies seem to have this enhancing function of the hippocampus. Could that also affect the likelihood of cabbies, not in London, but in the United States, of developing Alzheimer's? And this is really just a correlational study. I mean, we're not doing a natural experiment here that we could talk about what that might look like, but it's really interesting that you would see this. And ambulance drivers, these are not paramedics who are out there performing CPR. These are the folks who are driving the ambulances. So they got to know where to go, where to turn, how to get from one point to the closest hospital. They have to have that working navigational and spatial processing and memory intact.
I love that. That's so interesting. I was thinking, kind of a little unrelated, but sort of related. One of the companies I work with has a huge operation where they repair long distance trucks, big rigs. Mm-hmm. And what they were telling me was that one of the most significant problems that they have in that business is the truck driver would call them and say, "Oh, the truck's broken down," and they'd say, "Well, okay, we'll send somebody. Where are you?" And they're like, "I don't know, there's a light post and there's a yellow car and there's a blue house." And just locating where this thing was apparently a huge operational challenge because people are on roads, the truck driver's thinking, I want to go from point A to point B, but the stuff in the middle is just not that relevant.
Yeah,
so
exactly.
So what they're finding now
is
by putting sensors on these trucks, they can actually much more quickly and easily locate where the thing is. And apparently, I mean, it sounds so mundane, right? But it's one of those little changes that isn't that expensive that makes an order of magnitude.
Exactly, incredibly important.
Perishable
in there that needs to get to point B quickly. Yeah, absolutely.
Really, really interesting. So back to medicine. We were talking a little earlier about the Boston Children's Hospital experience with surgeons and how surgeons prepare and how that affects outcomes.
So I got roped into this project a little bit by accident, but I'm glad that I was. So there's an anesthesiologist, a pediatric anesthesiologist named Steve Flynn, who's at Boston Children's Hospital. And he and his colleagues had this interesting experiment or this idea. And it starts actually not in medicine, but it starts outside of medicine. So if you think about professional athletes, professional singers, people in the military, lots of different occupations, where there's a performance that is very high stakes and high risk, where a lot sort of hangs in the balance. In those sorts of settings, it's very common for those individuals to rehearse, to warm up, maybe even to get coaching right before the performance. You see this, for example, in professional sports all the time. Now, you might then ask yourself, why doesn't that happen in medicine, where the stakes are also very high? And there are these discrete instances where people have to perform, surgeons have to perform, or in Steve Flynn's case, anesthesiologists have to perform. And so what they hypothesized was that if you were to coach physicians or trainees, people training to become clinical practitioners, if you were to coach them before performing a procedure, not weeks before, not hours before, but literally minutes before, almost just like a warm-up in coaching like you'd see in a professional sports match, could you improve outcomes? And so what they did is they looked at young kids, or these are infants really, at Boston Children's Hospital, who underwent intubation, which is when a tube is placed into your windpipe to help you breathe. For example, if you're having surgery, this kind of procedure is performed more than 1 million times per year. Not at Boston Children's, but across U.S. more than 1 million times per year. So it's incredibly common. And what they showed was that if you just did an intervention between 5 and 10 minutes, where you coach the person and you allow them to warm up before performing the procedure, the outcomes improved. So, for example, a critical outcome is, do you successfully intubate the infant on the first attempt, as opposed to having to go in and out, trying multiple times? You don't have to be a medical doctor to know that going in and out a few times is not a good idea. Ideally, you just do it on the first try. So they found basically, a 10 percentage point reduction in the likelihood that you'd have to do multiple attempts, which in this case is quite meaningful. Like out of 100 kids, 10 fewer kids would need multiple intubation attempts if the provider who was performing those procedures had been coached and had a warm up just before the procedure. So it's sort of a fascinating thing because we don't do that in medicine.
Mm. Yeah, and we've talked about in other professions, so sports teams, right? I mean, they get warm up and coaching before, and then they watch the tape afterwards, and they say, how did we do? How could we improve? And that's taken for granted. And, you can't tell me that winning a soccer game has more human value than saving an infant's life, right?
And some of these Boston sports fans might disagree with you, but I would generally agree.
I suppose there's differing points of view on that.
Yeah.
But I do think it's interesting, and we have the same issue in management, right? And one of the things I think that we may be on the brink of thinking about is, could AI in some way become that sort of acceptable coach? Because I think with humans, getting feedback from another human being, it's always really messy, right? It's always complicated, and giving feedback is difficult. And there's a whole academic discipline devoted to difficult conversations. But if it was just you talking to a machine about what the machine observed, then it sort of takes that out of it. And I think opens the possibility that maybe we get more objective coaching.
That's a good, interesting point. Yeah, I mean, just generally the question of feedback is important. I mean, I in the world that I operate in medicine, I think feedback is extraordinarily uncommon. Mm-hmm. Positive feedback is probably more common, but negative feedback, saying, okay, you did something wrong, it's difficult to say that to someone. In particular, I think because when those mistakes happen, sometimes the stakes are quite high. And so it's difficult to say that to a physician, because it's not like you're not trying to do the right thing. But sometimes people make mistakes, and I think that culture could definitely be improved.
Absolutely. Well, there was some really interesting work, and I think it started with my good friend Amy Edmondson's research in hospitals on medical errors. Yeah. And they assembled this whole complicated study, and she felt, her hypothesis was that better performing teams, as evaluated by one group of researchers, would have fewer medical errors as collected by another group of data sets. And so there were two different sources of the data. And I think that's important, because the same source would not give you the right answer. And then her job was to collect the medical error data and compare it to the team data. And what she found was completely contradictory to her initial hypothesis, which was the teams that were evaluated as being higher trust, more collegial, just generally flowing better, actually had higher error rates than the teams that weren't. And so she basically thought her days as a PhD researcher were over. Her hypothesis had not been supported. And then a little idea came to her, which turned out to be a super big idea, which is, maybe that wasn't it. Maybe it was that the teams that were working together more effectively simply felt more comfortable when an error had occurred. And so they went back and redid the work, and they found out that indeed that was the case, that when you did a deeper dive into the medical errors, when you looked at the patient outcomes as an addition to the original reported medical errors, that what they found was that the teams that didn't work so well together actually did have higher error rates as shown in the patient outcomes.
That's interesting. I mean, this is sort of a chicken and egg issue in the sense that, when you see someone speak, or when you see a group of people who are speaking openly to each other, that either means one of two things: either that they have very bad personalities that they don't know how to filter themselves, or that they feel so comfortable with one another that they can speak openly. And you can certainly imagine that if you were to observe a team, and if I were to go into a hospital, I see how a team interacts, and everybody's very pleasant with one another, you would think that would be a good thing. And probably in most cases it is a good thing, but the sort of the niceties that you might see might be reflective of the fact that people don't feel comfortable being truly open with one another when things need to be discussed in an open way.
Yeah. I think that's super interesting. And, it ties back to this idea of the warm up and the prep. I mean, as we were talking about at one point, some years back, there was this notion of the checklist, right?
Yeah.
And if you institutionalize a checklist, you're just much less likely to make a mistake because you were rushed or you forgot, or some procedure didn't get followed. And so that was started, and everybody thought that was great. And I think it was Atul Gawande that was very instrumental in that movement. But then they discovered a problem, which was that physicians just sometimes ignored basics of the checklist, like washing their hands or whatever. And what they discovered was the problem was the power distance between the surgeons and physicians and everybody else who was in the operating theater. So the subtle shift that was made was they put the nurses in charge of the checklist.
Yeah. I
thought that was such an interesting example of how these power dynamics can inadvertently lead to outcomes that nobody wants.
Yeah. But, you mentioned AI earlier, and I could certainly envision a scenario where, you're a physician working in the hospital and you evaluate a patient, and, you typically would sort of make that evaluation, make an assessment and plan, and you write all that stuff down in a note, which nowadays gets published in the electronic medical record. Many decades ago, it would be published in a paper chart that sat at the nurse station in the hospital. But it certainly would be feasible for you to then take that note and run it through an AI algorithm that says, look, what have I missed here? Give me feedback on my note, right? So this, the benefit of that is that it's anonymized feedback. It's anonymized, but it's anonymized in an important way. It's that you're getting the feedback from a computer. It's not like a colleague who you have to open yourself up to and be vulnerable and say, what did I do wrong? And then listen to that feedback. You might disagree with the computer, but at least you have that feedback in a way that makes you feel more comfortable receiving it, I think.
Yeah, there's an interesting application of AI with salespeople. So what this program does, and it's really fascinating, it sort of listens in on calls between salespeople and the customer.
Mm-hmm.
And then at the end of each call, or whenever they tell it to, it gives the feedback to the salesperson. It sort of says things like, do you realize that you interrupted the customer 4 times? Or the customer had already asked for a purchase order and you were still explaining the benefits of the product when the sale was basically over. And it's done machine to person. So it tries to take that critical personality out of it. And if you're a salesperson and you're motivated by making more sales, actually it should align your interests.
Yeah, no, exactly. And I think that's one of the challenges that we see probably in medicine, all occupations, that there has to be an alignment of incentives, but B, that has to be clearly perceived by the parties involved. I mean, in medicine, if someone makes an error, they clearly don't want to have made an error, right? And they would like to have that information, but it's costly for them to receive that. And they might not always think that the information that they're getting will change practice down the road in some way. They're like, oh, I made this mistake, but I won't make this sort of mistake again. So I don't really know that I need to get the costly feedback from someone. But in your case here, so it's sort of real-time feedback. Do this differently. You implement that on the next case and you see whether you made a sale or not.
Mm-hmm.
And you sort of have that real-time evaluation, which is quite interesting. In medicine, they're doing similar types of things, not in the way you describe, but they have sort of computers listening in to conversations between physicians and patients. And the simplest thing that it's being used for right now is just to help with note transcription. So after a doctor sees a patient or nurse sees a patient, they have to write down everything that happened and summarize it and make a diagnostic plan. Here, the computer can listen to you and document all of the history, what the medications were that the person was on, what their allergies are, social history, all that stuff that goes into a clinical note. And maybe even if the doctor is explaining to the patient what their thinking is and what the treatment would be, also writing that down into a formal note, the way that a doctor would write that note for the electronic medical record.
Mm-hmm.
And the other thing that is quite interesting is being able to use that in a diagnostic way to say, either in real time or afterwards, what might the doctor have missed?
Mm-hmm.
So, for example, in mental health, there's the content of what someone might say that a human being could pick up on, but there's also the way in which they say it. So if they are speaking more rapidly, or if there's an urgency in their voice, human beings should be able to pick up on that, but they might not. But machines certainly can see that. And so you can imagine that there's other bits of information that a computer could tell you besides literally the content of the language that's coming out of that person's mouth.
That's super interesting. So I'd love to chat about something you and I exchanged a couple of emails about, which is, our healthcare system in the U.S. is just it's a mess, right? In many parts of it, the sort of treatment of chronic conditions, people's frustration at their health insurance companies. A healthcare CEO got murdered on the street because of some frustration. And what struck me about that incident was it's pretty horrific that a human being would be murdered for their job. But the reaction of a lot of people was sort of awful. It was basically saying, yeah, we sympathize for the human being, but the system that person ran was not serving our needs very well.
Yeah.
And one of the things I don't think people understand very well, particularly with the complexity of things like pharmaceutical pricing, is that many of these systems are set up in a way that nobody would have done had they been designed from scratch. I mean, a lot of them were set up in the sort of post-World War II employment compromise, which tied health benefits to your employer. And one of the reasons that was a policy decision that got made was that the companies at the time were really looking to have as much full employment as they could. Mm-hmm. And the goals were try to build a healthy middle class, support the suburbanization, make sure there's a job for all of these, people who had been at war and been trained to kill people. You really don't want them living on the streets in despair. That's not a recipe for a safe society. And so there were all these motivations, and in the early days, it worked pretty well. But now that whole system seems to have outgrown its usefulness. And you made the point that, yeah, we pick on the pharmacy benefit managers who are like the middle people in the sale of pharmaceuticals, the pricing of pharmaceuticals. We pick on them because we can tell what their numbers are, but that the bulk of healthcare costs are actually elsewhere.
Yeah. I mean, you might just ask me the meaning of life, and then we can.
Well, if you want to go there, I'm open.
Exactly. It starts, yeah. I mean, there's a lot to sort of say about these issues. Maybe I'll talk about this. I'll end on the note you just kind of mentioned. But when we think about healthcare systems, if you look at the data, and it's not great data, it's like survey data across different countries. Most people aren't happy with their healthcare. Well, people are similarly happy with their healthcare across countries. There are differences, but they're not dramatic differences. So I think that we have to have the recognition that people in the UK, if you survey them, 95% of them aren't going to say in surveys, and this has been shown, that they are happy with the healthcare that they receive. In all of these cases, there are clear trade-offs to be made. If we want to have a healthcare system where the proportion of our income, the share of our income that goes to healthcare is low, we will have to expect different access to healthcare resources than in the system where the share of our income that goes to healthcare is much higher. And that much is going to be true. If you look at objective measures of health, like you mentioned, chronic disease, obesity, those types of measures, we do perform worse than other westernized countries, other developed countries. And a natural thing to do is point our finger to the quote unquote healthcare system. Then my question will be, well, how do we define the healthcare system? The way I define the healthcare system are the hospitals, doctors, the nurses, the therapists, the rehab facilities, the nursing homes. Those are all the healthcare system. Those have a part to play in chronic disease, but they don't have the most important part to play, right? That comes from a lot of different factors. And I'll just give you one, what I think is a sort of a Freakonomics style data point that I always latch onto about this, which is if you look at doctors and nurses and you compare them to the rest of the population, let's actually take lawyers, compare doctors to lawyers. So similarly educated, similarly wealthy in society, but doctors have great access to knowledge. They have great access to medical care. The healthcare decisions that they make are not remarkably better. It's not like no doctor has a problem with obesity, or no doctors smoke, or no doctors have diabetes, type 2 diabetes. These things happen, and they happen because the behaviors that are sort of important for chronic disease are difficult to control a lot of times. So I don't know that fixing the way that we pay doctors, fixing pharmaceutical pricing, fixing PBMs, fixing long-term care, all those things are going to be the key drivers behind chronic disease prevalence. It might be important, but I don't think it's the only thing that matters. And so when I compare the U.S. healthcare system to other healthcare systems, I personally draw that divide, though I recognize many people do not. I think they reasonably expect that if we spend close to 20% of our national income on healthcare, we should be living longer than any other country in the world. But there's a reason we spend 20% of our income on healthcare. Part of it is because we're less healthy than the rest of the world. So it's, again, the chicken and egg problem that I just described. So I'll pause there if you have any reactions. We can talk about sort of drug pricing and other stuff in healthcare too, but that's just sort of like, is the healthcare system different?
Well, yeah, and there's a couple of arguments that I'd love to explore with you. One is that part of what we struggle with when it comes to healthcare is indeed the problem of being very wealthy, and we know that when human beings have more disposable income, they do things like they eat more meat, they eat more in general, their diets change, they often are exposed to less physical activity because they don't have to. They can drive their car instead of walk or take a bike, and so there is some kind of correlation with certain kinds of health conditions and just disposable income and wealth. So we can afford I guess, to be less healthy. So many people will indulge in that. So that's one that I think is interesting. The other thing that I think is interesting is the theory behind insurance. And, there's a lot of work that's been done, certainly in business, on what insurance does is across all categories of risk, right? It allows you to take relatively rare and unusual events that could be catastrophic, and you spread the cost of those catastrophic events across a large population. And what that allows you to do is create a buffer of resources so that for the unusual and rare situation that happens, there's an ability to cover that. And so people are willing to put themselves in more risky positions and take more risk in general. Things like, I'm willing to invest, in building a building, or I'm willing to invest in a technology, or I'm willing to invest in locating in a certain place, because if something catastrophic happens, I've got this backstop. And it's really been shown that the presence of insurance, as we currently think about it, is associated with higher growth and more stable societies and so forth. So insurance has a role to play, but that's about catastrophes. And when it comes to healthcare, we're looking to insurance to cover things like chronic care for diabetes and, regular checkups for older people and all kinds of stuff that it's not catastrophic, it's chronic. And so we've taken this one model that I think makes a lot of sense in the case of a truly debilitating or catastrophic incident. And now we're migrating it to this other model where we're sort of expecting a third party to cover things that are any other part of our lives. Would be, you pay to rehabilitate the furniture in your house if it's gone out of date, or you pay to maintain your car, and you don't expect a third party to be covering those expenses. And yet when it comes to healthcare, we do.
Correct. Yeah. When I talk about this in my classes, I give that exact example, which is that your car insurance doesn't pay for your oil change,
No.
whereas your insurer will pay for that annual visit to your doctor or for preventive care. Now, part of the reason I think is that it is possible that some of the preventive stuff that the insurer pays for they pay for it because it could be cost saving to them down the line. Preventive visits, maybe not. We're not great evidence on that, but vaccines would be great. So, you make vaccines free for people so that the insurer doesn't have to then pay for things down the line, like a vaccine preventable illness that could be quite expensive. So some things are actually, I think, cost saving in that way. But I think you're right. I mean, I'll just say one more thing, which is that there has been this push to think of insurance in a more catastrophic coverage sort of way. And we call these high deductible health plans. And these plans, like, they're attractive until they're not, right? That's sort of the problem, is that they're attractive when you're healthy, great, because you don't have to draw down on your deductible. But when something does happen and you have a $10,000 deductible, all of a sudden you're like, this insurance sucks, right? And that's the challenge. And part of the problem is that people don't sort of realize that that event might have happened to them, but not many other people. And also, even within that person, it might have not happened to them for many years. So there'd be many years in which they didn't have to spend $8,000 per year or $8,000 at once for some important medical life event. So all the savings that accrued for all those other years, the mind wouldn't really think about that, even though that you should kind of think about that in those kinds of plans. But I think, like, when I look at American healthcare, one of the areas I think is a challenge is that people sometimes feel like the quality of the care that they're receiving and accessibility is not what they would like it to be. And another way to frame that is, if we spend close to 20% of our national income on healthcare. If we felt like whenever we needed to see a primary care doctor, whenever we needed to see a specialist, we could. If we had commensurate health outcomes that were just way better than the rest of the world, would we be having these discussions? We might. It's possible that we might. But I don't think we're obviously not at that place, both in terms of the outcomes and I think in the perception of people to have access to care. I mean, one of the things we care most about is our health. But I would imagine that someone like you is probably very well connected to various folks. Even then, to get seen for something, you might have to make some phone calls and cross your fingers that you can get in earlier than 2 months or 3 months. And for something that matters to you, right, like your health, it's not a home renovation, right? It's something that needs to be done. You care about it. You're not going to be thinking about it. You're going to be thinking about it until it gets fixed. And I think that access is a big issue. So I would actually be in support of spending more if we could deliver care quality that people really value.
Well, it's interesting. I was talking to Paul LeBlanc, who's the former president of Southern New Hampshire University, and he has an idea that I think is really interesting. He said, if we could use AI to allow people with, call them, middle-level credentials to do more sophisticated work. So instead of taking an advanced physician who takes $10 million to train, or whatever the number is, I don't know, it's at least $1 million, right? And if you could instead have a nurse practitioner or some other kind of practitioner use AI to do some of what we sometimes expect those people to do. So diagnoses, or what's the most likely thing going on here, or what would be a no risk next step that I could do for this patient. So if you had a lesser expense person able to do that, what that would free up then is budget so that you could, as he puts it, flood the system with humans. And so he's working right now on a startup to try to do some of that re-engineering. And one of the examples that he uses, and he's got a great book out called Broken, which is about these systems of care that are just letting people down, of which healthcare care is one. And he uses the example of One Medical, where the founder of this company kind of came to the same conclusion, which is access is a huge problem. And so what they'll do at One Medical is the clinician will spend a relatively short amount of time. So let's say patients struggling with their weight or something, and the clinician will say, cut down on your salt intake and try to lose 10 pounds, right? And most of us go to the doctor and we hear that and we're like, okay, I'll make a note. And then we go home and we do exactly the same thing we were doing before. And, like, adherence is such a big issue in healthcare. But what they do at One Medical is they now have your health counselor. So the doctor leaves, right? The clinician leaves, and the health counselor says, "Okay, let's talk about what did you eat last week, and who does your grocery shopping with you? Oh, your niece helps you. Let's call her and find out what And so there's a whole, and then they follow up. They say, "Hey, tell me about your diet today," and so forth. So what you're doing is you're saying, instead of what somebody once described to me as the American healthcare system is the best or nothing. Instead of the best or nothing, maybe we have this layer of care that's provided because we can save money on the really higher end, highly trained folks and put people who are competent people, but don't need to have that extreme level of training in the position of delivering some kind of care. And I'm interested in that idea as a way of expanding access.
Yeah, I mean, it's just sort of an idea of triage. I mean, and you do that in the emergency room all the time, right? You triage the most complex cases immediately because you have to. We do a little bit of that now, and some of that is sort of self triage. Like, if you are really, really sick, you probably are not going to go to an urgent care. You might go to the ER, but we can do a better job even within healthcare systems of trying to do that sort of triage. The other thing I think that's worth noting is that we could also increase the supply of physicians. There are constraints on that right now. And historically, there have been constraints on that. We have about a third of physicians that practice in this country come from abroad. So they train in foreign medical schools. There's no reason why we could expand the supply of those physicians or train more medical students in the US. That would drive down wages of physicians. It might have implications for what types of people end up going into medicine versus law versus business or engineering, whatever they might go into. But it wouldn't be crazy to think that would improve access, right? We do that in other markets outside of medicine. So I think that would be useful. One sort of statistic that I reflect on, and I say this because I was just in the hospital a couple of weeks ago working, is the amount of time that doctors spend with patients. So there are studies where time use studies, and the average visit between a doctor and a patient's something like 16, 17 minutes, something like that. And that's really low, right? I mean, it might be fine if it's really just a quick checkup, and you're, talking about lifestyle, diet, exercise, that kind of stuff. That's fine. But if it's something that's significant, a new diagnosis that has to be made, starting a person on a new treatment path, a more serious diagnosis, like cancer or something else, those conversations can't happen in half an hour meaningfully. They probably can't even happen in an hour, meaningfully. This is something that takes a long time for someone to be comfortable with, to feel like that they were really treated. And I would like to see a healthcare system where people can feel like that when they have those kinds of problems. And a healthcare system where if the advice is going to be diet and exercise, that doesn't have to take a long time. It may not even need to come from a medical doctor. But when it counts, it needs
to get that on YouTube.
Exactly. Yeah. Just that guy on YouTube. Yeah.
That's great. Oh, that's great. So another thing that this sort of thinking of the supply of doctors, and it gets to the issue of access, but a very specific kind of access, which is the notion of health inequities. And I work with one of the big pharmaceutical companies that are very concerned about this, and trying to broaden access, trying to improve access. And what they're finding is that your zip code determines so much about what's even available. And if you think about even clinical trials, there's been a lot of research which shows that the clinical trials tend to be concentrated in very specific areas. So where's the primary investigator located? Where does the center have the facilities to actually do it? Where can patients come to? And so I think the government recently passed some regulations about broadening, clinical trials, but improving health access more generally. But a concerning statistic for me just came out a week or two ago, and it was that the number of Black and Latin medical school acceptances has gone down since those characteristics were sort of banned from being taken into account when you populate a class of potential future doctors. And I can only imagine that's going to exacerbate those kinds of problems.
Yeah. I have two thoughts on, or maybe three thoughts on that. So the first is that I think one of the key things that we can do to reduce disparities comes actually in the form of pharmaceuticals.
Mm.
So, if you think about most medical problems, how are most medical problems solved? Most medical problems are solved either with time, meaning things get better on their own, like a viral illness, um, with some sort of procedure, like a surgery or a device, or with a pharmaceutical technology, something like a medication, a biologic, something that you take that makes you better, right? Now, medications, the nice thing about them is you can ship them to someone's house, right? The problem of access, literally, that there's no doctors who live near you, or there's not doctors who accept your insurance, or if you don't have insurance, there's not doctors who are near you who won't see if you don't have insurance. That is a huge access barrier, and that is differentially concentrated across the country depending on where you live. You mentioned, for example, minority communities, but the same thing would be true for rural communities as well, like where there just might not be a lot of medical providers in that area. But for a lot of the conditions that individuals might have in all of these areas, many of them are going to can be improved with medication management. And so that, to me, is sort of, if I were to try to figure out how do I improve disparities, I would be putting most of my effort in trying to figure out how do we get the right diagnoses and treatments to people as easily as possible. I think, building a healthcare system that can reach all these other places is important, but it will take longer to do than just making sure people can get diagnosed and put on appropriate medications, because that's an easier sort of fix. So that's the first thing I'd say. The second thing I'd say is that, these are problems that you can only solve if you care for them deeply enough and are willing to pay for them. So, for example, if we want to improve access in underserved communities, we have to be willing to pay doctors, nurses, therapists, et cetera, more to practice in those areas. Right now, we have a Medicaid system that does a lot of good, but it's not known for compensating and reimbursing healthcare providers a lot compared to commercial insurance or even Medicare. So if we care about something, we've got to be willing to pay for it. And I don't think we're willing to do that. And then the third point I'd make, it relates to sort of this observation that you made about differences over time in the makeup of those who are training to be medical doctors. A few schools, in your neck of the woods, especially, a few schools have made medical school now tuition free.
Mm-hmm.
The idea that by doing so, you could encourage students to enter into primary care because they don't have medical debt and things like that, and encourage populations of students who are historically underserved to matriculate into those programs. And the data suggests that not a lot of this is happening. Right? What's happening is that these schools, and I understand why they're making medical school free, or really what they're doing is attracting the brightest of the bright who say, okay, I'm not going to go to this medical school. I'm going to go here now because it's free. Do you see individuals from those schools being more likely to practice in internal medicine or family medicine or pediatrics, or to ultimately settle down in underserved communities? We haven't seen any evidence of that occurring yet. So that, as a policy tool to fix this problem, is not something that I see working right now, at least.
Mm-hmm. Which is interesting. So a lot of your research and the discoveries and a lot of your writing really has to do with issues that end up being policy issues. I mean, some of it's things people can manage on their own, but a lot of them have to do with policy issues. So how do you see ideas from research like yours getting a hearing, getting actually enacted into policy? Because a lot of our policy positions, haven't been scientifically tested. Like, did this thing that we thought would happen? And there's a ton of places in healthcare where a lot of the assumptions that we made just haven't been borne out. And for example, there was this theory a while ago where, hospital consolidation is going to allow costs to go down because they'll have economies of scope and scale and they'll be able to purchase at higher rates. And the evidence I've seen anyway suggests that's not what's happening, that hospital consolidation is actually causing costs to go up. And so how do you see these sort of insights translating into policy outcomes?
Oh, okay. So let me pick on this last one for a moment, because it's quite interesting. So on the issue of hospital consolidation, right? When we think about consolidation, we worry about prices going up because firms consolidate and they have market power in an area. and they have the ability to charge customers, whether it's health plans or individuals, higher prices. That's a concern that we have. And the interesting thing, or maybe not so interesting thing about prices, is they're easy to measure, right? So you can easily measure whether prices go up when a market becomes more consolidated. What is harder to measure is whether the quality of care goes up. And so let me give you an example from my own sort of market. I live in Boston. There's a number of large medical centers. And there's always issues around, or issues that are concerns being raised about the big hospital systems acquiring smaller hospitals in the community. And the concern that's raised is that prices will go up, which that may happen, and you can measure that directly. What's harder to say is whether or not a community hospital that's 45 minutes or an hour outside of Boston, whether patients who live in that catchment area would now be able to access better sort of specialized tertiary, quaternary medical care than they otherwise would have been able to. We don't study quality in a very refined way in these sorts of analyses. And I would hypothesize that maybe what you'd see is that if a person who lives 45 minutes, an hour away from sort of the motherships here in Boston is newly diagnosed with cancer, they may be able to get plugged into a clinical trial at one of the major teaching hospitals earlier than they otherwise would have, or maybe they wouldn't have before, or they'd get access to more specialized treatments and therapies and doctors than they would have. All of those things are possible. I think all of those things are part of the objective of these hospital systems that are making these acquisitions. But nobody has really looked at that quality in a very sort of nuanced way. It's sort of, do we see heart attack mortality go down when the hospital becomes more consolidated, hospital system becomes more consolidated? And the answer is those kinds of things you don't see. But if you step back, you'd say, well, would I really have expected that to be where quality improvement would be discernible, would be seen? And the answer might be no. So that's just an immediate thought on sort of the policy issue around hospitals. On the broader issue of sort of policy and science, one thing that I've been thinking about quite a bit recently is sort of separating science from what you might think of as preferences or values. And I think we've seen this a lot in the last few years. Maybe COVID-19 could be a great example, right? So there's the science of how COVID-19 spreads. There's a science of whether or not requiring individuals to wear masks actually reduces transmission. There's the science of whether or not vaccinating particular groups of individuals reduces their risk or reduces the risk of transmission to other people. And those are all sort of pure scientific questions. In economics, we call those positive questions, in the sense that we can get a yes or no answer to them, right? There's just a yes or no question. If you study it properly, you won't really disagree. You shouldn't disagree about what the answer is. But what increasingly happens is that people have values and preferences over things, right? So someone might have a preference not to wear a mask, even if the science is strong in support of using it. And vice versa. Someone might have a preference to wear a mask, even though the science may not be strong in support of it. And instead of debating on the science and the values when it comes to policy discussions, really what people are doing is using science as somewhat of a crutch to justify that. I would say, look, the science says this. Really what it is that you feel comfortable wearing a mask and another person doesn't feel comfortable wearing a mask, whatever it might be. But you're using, not you particularly, but people are using science as sort of a surrogate for what they believe. And that sometimes makes the conversations easier, but also more difficult. It makes it easier because you don't have to confront the reality of the issue, which is either the science says something different than what you think, or that actually the science isn't great on that topic. And it makes it harder in the sense that people aren't being transparent about those things. So I think that that's a big issue we have to tackle with. It feels like it's become more relevant in recent years, perhaps because science is more in the mainstream. People talk about it more. People are more educated about sort of scientific findings and things like that. But I don't know if you have any reactions to that, but that's at least something I've been thinking about.
Yeah, well, the prevalence of Dr. Google, and now we got Dr. ChatGPT and Dr. Claude, and all those, it can give people the illusion that they are tapping into these sources of knowledge, which perhaps they didn't have before. So I think that's a risk, right? Although I think generally my feeling is the more educated people can get and the more knowledge that they have, I tend to have a bias toward thinking that's a healthy thing. So in business and management, we talk about this a lot. And among the things we talk about are heuristics and biases. And one of the most frequent and common is something called the confirmation bias, which basically says, we form a view of something, a preference, if you will, and then we go out and look for evidence to support that preference. And we ignore the evidence that would call that preference into question. And it's a very hardwired human brain thing. You have to make a real effort to get people beyond it. There was a fascinating piece of research that was done around gun control. Mm-hmm. And it was a report that was written, and the 9/10 of the report was exactly the same. So the same exact words and findings and research, but the last 10th of the report was the recommendation. And the recommendation was different. So there was one recommendation about really strict gun controls and what that would do. And then there was another recommendation said, actually, based on the data in this report, really strict gun controls aren't going to have the outcome that we desire. We recommend this other thing. And so what these scholars then did was they asked people who they knew had a position already determined on one side or the other of the gun control issue to read the report. And here's the interesting thing. The people that were in favor of gun control, who read the report that said the gun control was a great idea, thought this is a fantastic report. They rated it really high. They thought its credibility was amazing, as did the people who were on the other side. Now, here's what's fascinating. The people who, let's say they were for gun control and they read the report that said, no, gun control is not a good idea. Not only did they not believe it, but when they were tested after a month, after reading this research report about their views on gun control, their views had actually strengthened relative to the people who read the report that was in total agreement with them. So it's not only that we have this bias, it's that we will, like the line in the old King of Siam, Anna and the King of Siam movie, a man will fight to prove that what he does not know is so.
This is so interesting because we had this piece in Time Magazine where we're essentially making this point, mm-hmm. and the issue of gun control, it actually didn't make its way into the final piece, but I didn't know about this study, so I'm gonna have to look it up afterwards and familiarize myself with it. But it was exactly this point, and I wish we had known that there was actual research behind it, because the point we were making was, if someone believes in the right to bear arms, will they be convinced by a study that shows, a highly credible study that shows that guns pose safety risks? No, probably not, right? I mean, we know that that's probably true, but there's still trade-offs that we make as to whether or not we allow people to have guns and in what settings. I think this comes up, you talked about policy. Think about alcohol and health. There was a recent report by the Surgeon General about the safety risks associated with alcohol. And it's interesting because if you look at sort of the response of people to that report, I think people who generally like to consume alcohol are going to think that the studies supporting it, the Surgeon General's report, are not high quality. Whereas if you don't have a strong preference about alcohol, you might think that they're higher quality. But ultimately, the truth is probably that at very high levels, and certainly at high levels and moderate levels, high levels, there are problems with alcohol. At lower levels, we don't really know very well. The study qualities aren't great, but there's a lot of things that go into the decisions that we make about our lives besides just the science between how something we do affects our health. We think about quality of life and other factors as well. And so we've been able as a society to make those sort of determinations based on what is the existing evidence, what's the quality of it, and what are the values that we have in place.
Mm-hmm. Well, and I think we forget that everything's a trade-off. If you want universal access to healthcare, you're going to have to spend a lot more than if it's restricted in some way. If you want everybody to have access to the latest treatments, you're going to have to make a decision one way or the other. As I mentioned, I work with this pharmaceutical company, and something I had not appreciated was that if you're making, say, a cancer drug, the willingness of a country's medical system to pay the price you want for your cancer drug actually varies tremendously across the world. Yeah. And one of them was telling me that, well, in New Zealand, the government has made a decision that they will not allow a treatment to be paid for by the central medical budget unless there's at least 2 or 3 competitors in the market that offer something similar, and then that will cause prices to kind of normalize to some level. And I thought that was such an interesting articulation of a policy choice. And what they basically said was, we've got a whole population we've got to look after. There's only so many resources we can use. And if we take the brand new, super high priced, cancer drug, which is affecting, call it 100 people in our country, that means a depression of care for a whole lot more people that we, can't afford. And I think what we're not great at doing is having these discussions of trade-offs, we focus on the one human story that is, tearing at our heartstrings, and we ignore all these other stories. The other thing that I think is really interesting, and the sort of relationship between pharmaceutical companies and the rest of the system is fascinating, is, where the money gets made. And a topic that my mother, who was a microbiologist, was a very big scientist. Yeah, so my mom was a microbiologist and my dad was an organic chemist. So I grew up in the kind of house.
Yeah.
If you had a question about anything, the answer was in a book, and you went to the book and you found the answer, and it was a black or white, yes or no. So that's the kind of household I grew up in. But she was fascinated at the idea that there are many treatments for patients that are suffering from debilitating diseases that are just not very profitable, and so they kind of get ignored. And I have often wondered if there's a policy angle to saying, well, if there is something like that, maybe we should have a not-for-profit structure or some other structure which will allow those things to be brought to market. Kind of think about it.
Yeah, I totally agree. I mean, this issue, and it's not even for smaller diseases. There are certain diseases, I think of, for example, sickle cell, which is, it's not, I mean, it's classified as a rare disease, but there's certainly many more diseases that are quite a bit more rare than sickle cell. But the population that is affected is not a wealthy population in this country. And so whether it's cause and effect or not, it's hard to say, but we haven't seen much improvement in this space until recently, when there have been treatments, gene therapies that are being evaluated for sickle cell. So I think the future is going to look a lot more promising than it has in the past. There are policies that have been in place that try to stimulate and incentivize innovation in these areas, and they seem to have worked somewhat. For example, the Orphan Disease Act did a lot to improve innovation for rare diseases. But I think if you talk to someone who has a rare disease, their answer is not that we need less innovation. And the other thing is, this goes back to your point about insurance, right? I would like to insure against the possibility that a very rare but devastating outcome could affect somebody that I care about. And this is exactly what we're talking about when we're talking about rare diseases. So this is precisely the place where you'd want to make those investments. And the other thing that's important to know is that, when you make that investment, the knowledge doesn't go away. So it's not like, a nice meal where you eat it and then it's gone. Once that knowledge is created, it will always be there and it can be built upon. And so I do think that we need more incentives, not less incentives for those kinds of diseases. And it is the sort of place where I think the federal government should play a role, because really what we're talking about is, in some sense, that insurance aspect, but it's also about altruism, right? We have Medicaid because we're altruistic. These are programs and drugs where we might be altruistic towards people who develop those conditions, where we should have more, not less innovation.
Such a great point. So something else that I think is interesting in the policy realm is how often decisions made at a policy level have these unintended second or third order effects in the kind of business of medicine. So I was talking actually to the CEO of a large pharma company about the Inflation Reduction Act. And one of the things the public, I don't think, understands very well is what that act did. And I don't know the reasoning behind it. I have my suspicions, but what that act did is created two different patent cliffs for two different classes of medicine, where you have this, I guess, the small cell treatments that are mostly oral versus the large cell treatments, or maybe I have that the other way around. But anyway, there's two different things. They're both medicines, but the incentive of a pharma company to invest in something that has a shorter patent life is just much less than to invest in something that has a longer patent life. And ironically, the cheaper and less difficult to administer and kind of broader sweep of the medicines are the ones that are being put under a shorter patent cliff. And I was talking to the CEO who said, yeah, it totally is affecting our portfolio investment decisions. And the other thing that that act did was it said, okay, for a very rare disease drug, charge whatever you like, and we'll hassle about it later. But if you take this same compound and make it addressable for more than one condition, now it's going to go under the Inflation Reduction Act, and now you're going to have to deal with the patent cliff. So this guy was telling me, he said, yeah, we're putting one of our very promising treatments on ice because we already have one that's out in the market. And if we put this one out there, we run the risk of falling under this act. And so I think, when you think about policymakers, I don't think they think this stuff all the way through.
Yeah, they might not. And, I think that the future of healthcare in our country is going to depend on life sciences. It's just, I tell students when you go to the hospital and, I'll just give an example of if a young woman goes into the hospital with abdominal pain and it turns out she has an abdominal infection and she's treated with an antibiotic, and let's say an old antibiotic to treat that infection. If she's lucky enough to live through that hospitalization, leave the hospital alive, who's she going to thank? She's going to thank the nurses. She's going to thank the therapists who helped her rehabilitate. She's going to thank the doctors. She probably is not going to thank the hospital executives, but she wouldn't thank the original innovator or the drug that was really critical. Probably the most important thing in helping her survive that hospitalization, right? Because these are things that you take by mouth or that are IV medications. They're not people, right? And I think people sometimes forget that, right? Like we, to great credit to doctors, and I understand the profession. I am a doctor. It feels good to make a decision, to make a diagnosis, to help somebody, but I would be helpless. Other doctors would be helpless without an armamentarium of things that they could use to treat people. And to think that we want to dissuade innovation in those things, like literally the armamentarium that we have, to me feels very foolish from a policy perspective. It's short-sighted. It doesn't sort of realize or recognize that the reason we have the health today compared to 50 or 100 years ago, a large part of it comes from public health efforts, for example, to reduce smoking, sanitation, clean water. Those things are obviously important. Air quality, important. But the other big swath of it is not the way that we train doctors, not the construction of the hospital buildings that look fancier now than they did 30 years ago, but it's the medications, it's the knowledge that is embedded within those decision makers. It's all the technology that's driving it. So we got to see more of that, not less of that.
Yeah. And I think with AI promising to creep into more areas, that we will. So my goodness, the time has flown. So for those of you who joined us late, I am here with Anupam Jena, who is a medical doctor as well as a trained economist, the host of the podcast Freakonomics MD, and a researcher who studies, as he puts it, random acts of medicine. So let's close with what are you excited about for this year and maybe the year or two to come?
Oh, excited. I'm excited about living my life. I've got a good life. Awesome. We're talking today at 3:00. It's 20 degrees in Boston. I had a chance to play soccer during lunchtime. That's what excites me most.
That's awesome. And where do people go to find more? Clearly, you have a book website. The book is called Random Acts of Medicine, as I mentioned. Any place else you'd like? Well, and your podcast. Anything else people should look up?
Well, we're starting something with Time Magazine. So if you Google my name and Time Magazine, you'll start to see some articles and video clips pop up. So we're excited about that. And yeah, that's it.
That's great. Well, thanks so much for the conversation. I always learn so much when chatting with you. Likewise. And until next time.
Thank you.
Bye.